So you have sort of an imbalance, and one of the questions that we try to answer is who should do it. It isn't necessarily us, but I think that we try to embolden the patient into asking the question of their surgeon, how many of these do you do a year? Many patients are shy about asking that question, but we think it's really an important part of the shared decision making. And the results in New York may or may not be the same as the results in Chicago or the results in Seattle. And part of those differences may be due to the experience of the individuals doing it. So I would like now, if you all are willing, to invite three of my very special friends to come up, and what I'd like to do is to ask these individuals to talk to us, you and me, a little bit about what their shoulder was like before they had a shoulder replacement. Then what I'd like to do is to take you through the operation, those of you who feel up to it, and then we'll have them come back and we'll talk to them a little bit about what life was like after the shoulder replacement. So Amy and Helen and David, if you can join us.
Okay, just a minute, I'll get my cane. Thank you. Okay.
We'll put you all over here and I'll sit down and we'll talk a little bit. And again, they're open field for all of you. This is my friend Amy Evans. She had a shoulder replacement done in 1993. This is my friend David Belvin, who had 2 shoulder replacements done in 1997. And this is Helen, his wife, who has been a really important partner in the whole process. And again, we try to draw the family in as much as possible because they become our allies as much as possible. So again, I hope you will join me in asking these folks a few questions. And again, thank you all for coming. So what I'd like to hear about, Amy and David and Helen, a little bit about how was life with an arthritic shoulder?
How was it with it?
With it when you had arthritis of your shoulder.
Excuse me. Before wasn't good. It wasn't good. It was hard to do anything, and as you can see, I'm not in my 20s anymore, so I had that to battle also, just age along with the problem. And he fixed it all.
What kind of things did you have trouble doing?
Oh, lifting, I didn't have trouble dressing, but lifting, it just, well, it just, everything slowed down, and it hurt. Didn't mind the slowing down as much as I minded the hurt. I'm a devout coward. And Dr. Matsen took care of all of it for me.
David, how about you? How was life affected by your shoulder arthritis?
Well, my motions really shut down on me rather rapidly. It took from the time of the onset to the time that I could hardly move was like about a year to a year and a half. So it was rather rapidly moving. And it got to the point where I could not take my coat off or put my coat on without help, even to the point of even working on my shoes. I could not do that by myself, or tucking my shirt tail in. That was an impossibility. Sleeping, I had to have pillows all around, and about the only way I could find a place to sleep is on my side, buffered by pillows, and moving anything that caused motion of your arms outside of just a very narrow range was getting to be intolerable.
So one of the things that's interesting about arthritis of the shoulder is often the shoulder function will remain good for a long time, and then all of a sudden, as David said, it'll stop. And this is, to me, a little bit like what happens when air is leaking out of the tire in your car, because it still rolls pretty well as long as there's some air in it, but there comes that moment when your rim is on the asphalt and all of a sudden you realize that there is no cartilage left in the shoulder. And I think that's one of the things that's so interesting, because people say, gee, it just came on like that. It really didn't come on like that. The air has been leaking from the tire for a long time, but the patient usually notices it when the rim meets the road. Helen, what sort of things did you notice about your husband's get-along when he had arthritis of the shoulders?
Well, I think the first thing I noticed was he'd get up to put on his shirt, and he couldn't quite get his arm in the shirt. And then the range of mobility deteriorated quite rapidly, so anything involving putting an arm in a jacket or a shirt or putting on anything over his head got to be increasingly difficult and then just about impossible. And then even, as he said, putting on his socks and shoes, he wasn't able to do that. And of course, things like mowing the lawn, which he'd always done, he wasn't able to do. And then when driving the car or just trying to close the door or any heavy door, that was painful. And so, and then at night, it was really difficult to try and get comfortable. So I went out and bought a whole bunch of pillows, different sizes, and we'd put them here and there. But he never seemed to be able to get comfortable, and that got worse and worse.
So the interesting thing is how many things you need your shoulder to do, and that's one of the things that we sort of got after with this simple shoulder test, and you found that when you have arthritis of the shoulder, you really have limitation in a lot of the activities. The big killer seems to be the inability to sleep, and I think that you all would probably agree with my friends and me that you can tolerate a lot as long as you can sleep, but if you can't get sleep at night, if you can't get those REMs you need, then it really tips over. And we find that if we can just back away from the topic of the shoulder for a minute, with almost all arthritic joints, it seems to be the loss of the ability to sleep that really brings people in. And so one of the greatest goals that we have in helping them restore function is the very simple and basic function of being able to get a good night's sleep. Please.
I was wondering, are you talking about rheumatoid arthritis or osteoarthritis?
Very, very good question. So the question is, are we talking about rheumatoid arthritis or are we talking about osteoarthritis? And it is an important question because there are many different kinds of arthritis. These two individuals have what we commonly refer to as osteoarthritis, although it's not necessarily always pure. And there are some individuals that have mixed forms and some people have purely rheumatoid arthritis. This particular procedure addresses the loss of cartilage, whether it's due to rheumatoid arthritis or whether it's due to osteoarthritis, or there are other forms of arthritis, such as the arthritis that occurs after an injury, or the arthritis that occurs when the ball dies from lack of circulation, what we call avascular necrosis. That is a condition that's becoming more and more common as our renal transplant program is helping people survive for a long time after transplants, but of course they need to take steroids for a long period of time. So one of the side effects of that can be avascular necrosis. So what we're sharing with you tonight is sort of an approach that seems to work quite well no matter what the cause of the arthritis is, and the reason for that is the thing that's common to all those different kinds of arthritis is the loss of cartilage, and that's what we're trying to restore here. Yes, ma'am? The question was, what causes the arthritis to go bad? In osteoarthritis, we used to think it was due to wear and tear. But a number of people, like David, have this condition on both sides, their dominant shoulder and their non-dominant shoulder. So the wear theory is part of the equation, but is not the entire thing. And so one of the things that we're finding out with our research is there's certain genetic tendencies to have cartilage that doesn't wear quite as well. So you know that different kinds of carpet will wear various lengths of time. It seems like different genetic brands of cartilage will wear various lengths of time. And so that's one of the causes, is some combination of wear and tear plus perhaps a not quite perfect cartilage. I'm not saying anything bad about you here. But in rheumatoid arthritis, it's something quite different. It's where people become allergic to their own cartilage. And this is what we call an autoimmune disease, where, for reasons that we still don't completely understand, the elements of protein that are in cartilage engender an allergic reaction, and the body tries to deal with that by unleashing a whole inflammatory response that looks much like an infection. In other words, the joint gets hot, swollen, and a lot of inflammatory cells move into the joint and start chewing on the cartilage and chewing everything in sight. And so that's another kind of arthritis. And by the time patients with rheumatoid arthritis come to us, they usually have burned out that inflammatory phase and are just left with a cartilage lacking joint. Other questions? Yes, sir.
How long is replacement surgery expected to last before going in again and redoing it might be attractive?
That's a very good question, and one that we get asked often, as you can imagine. And we find that the duration or the durability of the joint replacement depends on how well it's done and how well the patient does their rehabilitation, because it truly is a partnership. And so we have patients like Amy and David that have done a perfect job, and I expect their shoulder replacements to last as long as they do. But there are other people who have abused their shoulders, who do not understand that this is not a joint replacement in the same sense that you replace a spark plug in your car. This is a prosthetic joint, it's an artificial joint, and it needs to be used with that in mind. So it's not an operation for somebody that's going to go out and dig post holes for a living. But the prostheses that we're using now are very durable. The fixation that we've developed for connecting this to the bone is very, very durable, so there's no reason to think that they will ever wear out as long as they're used appropriately. Sir?
You showed some really dramatic data from New York on...
The question is, how does the frequency with which a procedure is done relate to the quality of the outcome? And I think that's, again, a very important question. We don't have the data specifically for joint replacements, but it is well known for cardiac surgery that there is a practice effect, and that hospitals and physicians that do something a lot will have fewer complications and shorter hospital stays and better functional results. There is some data that relates to hip and knee replacement that is very similar to the cardiac surgery data, but so far there's not much in the way of shoulder replacements. We know that the incidence of complications is greater, though, when people do these surgeries that do not have a lot of experience. And the way we know that is that fully half of our practice now is in doing revision operations of ones that weren't done properly. So yesterday, from 7:30 in the morning till 9 o'clock at night, I was in the operating room with Jan, who's right behind you there, doing revision after revision of previously failed shoulder arthroplasties, trying to get the parts back in the proper position, trying to get the scar tissue liberated, and so on. But it's not just the surgery, and I don't want to take anything away from the fact that it's about the patient. It's about getting the patient on board with the rehab program, and that's where Sarah Jackins, who's here with us, plays such an important role in sharing with them